Welcome, and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing Series. During this webinar, participant microphones have been muted. However, we do encourage you to make use of the chat box to communicate with the presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. If you would like to submit an operational topic for consideration for a future webinar, please write to us at ready@savechildren.org or use the chat box during this and future webinars. It is now my pleasure to introduce our moderator for today. From the Center for Global Chronic Conditions at the London School of Hygiene and Tropical Medicine, Professor Pablo Perel. Welcome.
Thank you, Ryan. And welcome everyone to this webinar. As you know, the topic for today's webinar is about people with NCDs in the context of a COVID-19 pandemic. I think I will be very short, brief, and I will introduce the panelists that we have. But basically, to put the webinar in context, I think it's now widely recognized the importance of NCDs in the context of the COVID-19 pandemic. I mean, at least the implications are twofold. I mean, people with NCDs are at higher risk of having severe COVID-19. And also the healthcare disruption that we are experiencing with the pandemic has an indirect impact on people with NCDs. And we are seeing this and it's reported even in high-income countries with well-resourced health services, and the impact, of course, in humanitarian settings is probably even larger. So to discuss this, we have three panelists representing a variety of stakeholders. We'll be hearing from Sylvia Kamati. She's from Kenya. She works for the Danish Red Cross, is in charge of Africa's project from the Danish Red Cross, and has a lot of field experience in the humanitarian setting. We'll also hear from Philippa Bull, who is from MSF. She's based in Geneva, and she is also the lead of the NCD group from MSF. So she has experience from the field, but also from the headquarters from an organization such as MSF. And we finally hear from Slim Slama, who is from WHO EMRO, and I think arguably we can say he has been probably the most, the champion from WHO in terms of NCDs in humanitarian settings. So we'll be here his view. There will not be presentations. We structure the session with 4 key questions that they will be discussing. And you can see these questions on the screen. These are what have been the major disruptions of care for people with NCDs in the context of COVID-19. What adaptations the NCD programs have had to respond to these disruptions, some of the key lessons learned so far, and we will discuss some priorities in terms of programmatic and research needs, and of course other related issues. Each of the panelists will have 10 minutes to discuss these questions, and then we'll have the rest, half an hour, the rest of the webinar to hear your questions. So please start sending the questions to the chat, and then we will have hopefully a very interesting discussion. So now over to you, Sylvia. I think if you can unmute yourself, Sylvia. Yeah, I can see you.
Yeah.
Welcome.
Great. Thank you very much, Pablo. Good morning and good afternoon to all of us. Some of us it's morning, others it's afternoon. I really want to appreciate this opportunity to just give some field experience on caring for people with NCDs in humanitarian settings during the COVID-19 pandemic. I would like to talk about a context, especially in the African setting, with a focus on Kenya, where we are currently, as Danish Red Cross, supporting efforts on NCD programming, of course, also in the context of COVID-19, but I'll also touch in terms of the other areas in the continent that are affected by this. I will follow the 4 questions. So I will start off by looking at what disruptions are we talking about. Pablo has just talked about the disruptions in service provision, the disruptions in terms of care, access to care for persons living with NCDs in the COVID era. And also one of the other things that we have seen that COVID has caused is fear for people getting COVID at key areas like the health facilities, therefore resulting in low utilization of health services. Now, just looking at one of the areas where we are supporting, which is a county called Meru in Kenya, we found out a few things in the last recent months since the country declared the first case of COVID-19, that there has been limited or no access to healthcare workers for service provision for persons living with NCDs. And one of the, this is due because most of the health workers either are not available to provide services because they don't have adequate PPEs and therefore they are not availing themselves in public facilities, or the population is not able to access them because they're already overwhelmed with the current COVID-19 measures that they are doing in the country, and most of the health workers have been diverted to undertake these services. Also, we have a heavily medicalized model of care, and therefore making it very difficult for the persons living with NCDs to take care of themselves because they have to rely on the healthcare workers to give them even basic procedures like glucose monitoring. Access to health facilities has been a challenge for checkups and appointments because right now we have a lot of health facilities that people are scared to go there because they think they'll get COVID when they go there. Persons living with NCDs have been, of course, highlighted as one of the most at risk or vulnerable group to contract COVID-19 or even die from it. So out of this fear, many people don't want to go to health facilities. But also on the flip side of it, most of our health facilities don't have very good IPC measures. So that also scares people off from going for checkups. And finally, also, we don't have healthcare workers, adequate numbers to provide these services. Then access to medication has been a challenge, diagnostics and screening supplies and commodities. We all know that supply chain has been disrupted, and therefore accessing the, key commodities and drugs like insulin, the first line drugs for most of these conditions, like most of the persons we are dealing with who are diabetic and also hypertensive have been struggling to get their drugs even from the public facilities because the supply chain has been interfered with. Then also we know from this program that we've been supporting that a lot of persons living with NCDs get their psychosocial support from what we call support groups. So they come together as a group and then they meet, they're able to support each other. But because of course of the physical distancing measures and some of the restrictions in movement and the lockdowns, we have these support groups not able to meet anymore. So this is affecting the mental health and the well-being of the persons living with NCDs because they can no longer rely on that social support structure that existed before. And also bearing in mind that these persons, living with NCDs have been they have seen their colleagues, pass on. Unfortunately, in a place like Kenya, a lot of the people who've died of COVID are persons with pre-existing conditions. So when you see like 1, 2, 3 of your colleagues passing on, this creates this fear and anxiety amongst them. So there's a lot of course, mental health stress that has been building amongst this population. Then the curfews and the partial lockdowns, restriction in movements have also, disrupted supplies of basic commodities like water, food, and also emergency care services for this population. There's one case that the other day we were seeing of patients who were on chemotherapy who would get their chemo sessions in one of the referral hospitals here in Nairobi. But because Nairobi has been locked down, partially locked down, so people can't get in and out of Nairobi, and these people are living in the rural area, so they can't come for their usual chemo sessions as they used to come for. And this, of course, as we all know, then interrupts treatment and, of course, then interrupts how people would then manage when they're having different NCDs. So what kind of adaptations have we had to do? I will just zero down to the program that we are supporting in this county in Meru. What we've had to do is basically adoption of very comprehensive IPC measures for the community health volunteers who have become very essential in terms of taking services to persons living with NCDs in their homes, because these persons can't leave their homes freely as they used to initially. So we've been working with community health volunteers who, of course, then they have to put on masks and they have to ensure that they're observing the highest levels of hygiene as they go and check on these populations, just make sure that they are coping. We've also been using a lot of shielding. So what we've done is ensure that these persons living with the NCDs are able to access masks and they're able to access hygiene products and materials even in their homes so that they are able to prevent themselves from getting COVID-19, but also they are able to freely do a few things for themselves. We've also ensured that their caregivers are well trained and well equipped on how to ensure that that they are protected. Then also remote checkups and consultations. We've had to introduce very simple mobile phone structures where we link the doctors and the nurses with the persons living with NCDs in their homes, and they're able to call, they're able to say what they're going through, and they're able to be given the clinical care that they require. But now this is being done remotely. A lot of focus now has been on self-care, and I think as I talk about the lessons learned, I'll mention that self-care is one of the key strategies that we might need to really work on going forward to ensure that patients are empowered to take care of themselves, and also the caregivers are given the skills to take care of this population, because this has become one of the best ways to provide services to them at the moment. Then of course, we also looked at working with the county governments and the national governments for this mini stockpiling of drugs and ensuring that the persons living with NCDs can get a stock of 2 to 3 months. Of course, it hasn't worked as we had planned initially, but at least some of them got their stock of drugs and essential supplies, and they've managed to survive. Then we also had the patient flow at health facilities reorganized. So some of our link facilities, some of them were converted into COVID isolation centers. Then other link facilities, then we had to reorganize the patient flow together with the county authorities and looked at how persons with NCDs are given a special attention, kind of. When they come to the facility, they spend a very minimal time there, and they're able to be given their services very quickly, so that then we don't have them spending too much time at the health facilities. So what lessons have we learned? I think I will mention 3 key lessons that we have learned in the process: that there is need to demystify, to demedicalize, and to digitize NCD management to promote patient empowerment and adoption of self-care. Why are we saying this? Because the persons living with NCDs need to have the capacity to take care of themselves, to self-monitor simple things like glucose monitoring, blood pressure, even giving themselves medication, do self-care. It's important for us to focus attention more on that and look at the interface of persons living with NCDs and the healthcare workers should be really minimized to a bare minimum where they really need to do that. And in Meru, we've been working with Red Cross, volunteers and the staff, and we've been working with community health volunteers to support this population in this kind of a self-care model. So we are looking at making diabetes, hypertension, cancer very understood to the population, and people be able to take care of themselves, and they don't have to rely 100% on the doctors and the nurses. It is important to have an NCD-sensitive health system preparedness and response to outbreaks and of either pandemic or epidemic measure. What do we mean by this? We've realized with COVID-19 and also with other outbreaks like cholera and the rest, that outbreak preparedness and response strategies lack the consideration and full appreciation of the reality of an increasing burden of a population of persons living with NCDs. And that this population will always be vulnerable because they're having a pre-existing condition. So when you have another disease coming, you will expect that they would always already be vulnerable. So we need to have the outbreak preparedness mechanisms, the response mechanisms, being able to adopt or to be NCD sensitive every time they're planning for these kinds of responses. And then of course, then we are also looking at, we need to develop and implement NCD in emergencies, SOPs and guidelines. And the Danish Red Cross is currently working with Kenya Red Cross in Kenya to develop these SOPs, review existing guidelines and protocols on emergency response to include NCDs in floods and drought. And also we are looking at now epidemics as the next frontier. And one of the things we are looking at is all these tools that are being used for emergency preparedness, rapid assessments, do they have NCD in them? You know, the protocols for response, the protocols for planning, contingency planning. We need to ensure that all these tools have NCDs in them, so then we are able to ensure that this population is not left out during preparedness and response of either epidemics, but also any other emergency that comes. Then of course, also this comes with other interventions like prepositioning and stockpiling for essential drugs and commodities for NCDs. I am aware of the NCD, the WHO NCD, response kit that was released a few years ago. And I think that can come in handy to support in that process, but then also just working with governments and different stakeholders to ensure that simple things like insulin are actually prepositioned before, and when there is an emergency, it's easy to then access. And if we have an emergency to this scale—
1 minute, Sylvia, please. One more minute.
Thank you, Pablo. Yeah, I just have one point to finish. And if we have an emergency to this scale, then, and the supply chain is interfered with, then it is easy for populations to access their drugs. Then finally, what are some of the priorities for programming? I think I will just say one priority that is very important is looking at NCD in emergencies. How well prepared is the healthcare system and other emergency response mechanisms to address needs of persons living with NCDs in whether it's an epidemic or pandemic situations or any other emergencies? How really well prepared are we, and how can we support these systems to be able to be well prepared to have NCDs addressed in emergencies. So I think I will end there. Thank you very much, Pablo and the team. I'll end there. Thank you.
Thank you, Sylvia, for those excellent points. And I'm sure there will be questions. Please remember to put your questions into the chat and we'll discuss it at the end. Now over to Philippa. Philippa Poole from MSF. Over to you, Philippa.
Great, thanks, Pablo. And hi, everybody. I think, in fact, Sylvia's just given a really fantastic overview and covered really a lot of the key points that I wanted to cover. So I'll try to go through those relatively quickly and see where I can complement the important points that she's raised. Just super quickly, in terms of MSF as an emergency medical humanitarian organization, we're working in quite a variety of countries around the world, from different contexts in Africa, rural and remote, as well as capital cities, in the Middle East, Central and Southern America, and even in Europe now with refugees, for example, on the Greek islands. So it's quite a variety of different settings. And of course, the challenges vary a lot in those settings. But I think, I mean, a lot of the points that Sylvia has highlighted are really common to those. So just in terms of the first point and the disruptions of care, certainly the obvious thing is the disruption to health services and patients' ability to access those. So we see a lot of different restrictions on patients' mobility in different places due to the lockdown, due to lack of public transport, and of course due to the need for patients to try and protect themselves from the risk of contracting COVID through contact with other people and through health services. And then, you know, clinics that are closed, or health services that are diverted to COVID response, and difficulties with health staff, either those who are at risk of COVID and no longer want to work, or Sylvia highlighted quite well the fear that exists in many settings, and the lack of PPE and the difficulties accessing PPE. And certainly that's something that MSF has had to do a lot of work on, because the challenges for PPE have certainly affected us as well, and really had to make us think about how to adapt our response, not just in terms of response to COVID, but in terms of ongoing health services. And then the supply issues Sylvia mentioned as well, but issues with difficulties with border closures, finances being diverted elsewhere, and general system disruption. But one thing she touched upon, which I'd also really wanted to emphasize, is the kind of disruption to the psychosocial world and support for patients. So this support system that normally helps them, that's really a challenge in the COVID situation, where they have disruptions to the family and social cohesion, decreased contact with their usual supports, and need to isolate themselves. But then on the flip side of that, the lack of ability to properly isolate and protect themselves, and that in, you know, the settings in which we work, patients may be quite aware of their risk of COVID, but actually they don't have the capacity to moderate that the way that we do, the kind of luxury we have in high resource settings of being able to self-isolate to try and protect ourselves. So people living in really crowded refugee camps, multiple patients or multiple people sharing rooms. Our team, for example, in Lebanon tried to do a little shielding pilot of patients living in Palestinian refugee camps. And having a look at the report of that, I mean, it was really clear how challenging it is, in the sense of you have people who are actually, I mean, vulnerable patients who are sharing beds, let alone just rooms. And so even being able to protect and isolate themselves within a one-bedroom facility became extremely challenging. The other kind of psychosocial issues, of course, we know that patients with NCDs anywhere in the world have increased incidence of depression and anxiety in patients with depression, and as with diabetes and cardiovascular disease. And so that's compounded in this situation. And they also have decreased access often to health services. There can be stigma associated with COVID, and in some settings we've had real questions or challenges about whether to support the community with use of masks, shortages of masks, of course, meaning we have to decide, should we prioritize those for high-risk patients? But then the challenges of realizing that that's going to create a lot of stigma for these high-risk patients and may actually be detrimental to them overall. We've also seen issues of increased food security. And like I'll highlight later on, I mean, I think this just highlights a pre-existing challenge with managing NCDs, and particularly an NCD like diabetes in our settings, where patients really have very limited access to food. It makes it extremely challenging and unreliable access to food. And so in some settings, such as South Sudan, our teams really struggle to manage patients with diabetes who are on insulin, not knowing whether they're going to have a meal every day. And some of that we've seen that exacerbated in some of our settings where there have been decreased food distributions, for example, due to the COVID. And just then, I mean, another disruption for the kind of humanitarian response for us, it's been limitations on ability to move our staff, both national staff, but particularly international staff, meaning that even as the stakes increase and even as things become more challenging in our settings and patients more challenging to manage, we're having to deal with limited HR and also lack of experienced HR in that management, and of course trying to protect staff who are at risk of COVID themselves. And then another issue that I think is quite important in terms of the disruption to care for people with NCDs is more of the global work that's being done in trying to improve the situation for patients living with NCDs in humanitarian settings. So particularly looking at the work on diabetes and on insulin. There are a couple of initiatives that were planned during these last months that were postponed. So two important ones being the WHO pre-qualification of insulin and a meeting that was to be held bringing together some key stakeholders looking at the issue of thermostability of insulin. Both of those are really sort of important towards improving access to care for patients with diabetes in our settings, and both of those have been postponed. So just two examples, but just the fact that the kind of disruption of the global work for these patients is an issue. So in terms of the adaptation for MSF NCD programs, I think, and we've done a number of the things similar to Sylvia's teams and elsewhere in the world. We developed some guidance for the teams, just looking at how they can adapt their care. And so in various settings, we've done some key things. Where possible, we've absolutely tried to space out the patient visit so that they have decreased need to visit the health facilities. Sometimes that's been limited by supply issues, but where possible, giving patients at least 3 months worth of drug supply. Again, another challenge with this, the issue of insulin, and teams asking how much insulin they're able to give patients who don't have access to refrigeration and live in very hot settings. We've been implementing telephone consultations and follow-up where possible. And then where we've had the time to prepare, really trying to focus on those high-risk patients. And again, the issue Sylvia raised of trying to make sure we emphasize or reinforce patients' self-management skills and patient education skills. So ensuring that patients who are able to use glucose meters and understand them, have them and can use them. But again, that's something that's quite limited in general in our settings. And so that has really also highlighted difficulties of managing patients when you have this kind of remote follow-up. And then, yeah, and so in some settings as well, where there's been, well, where there is presumed to be a pending kind of overload of, or potential overload of the services and the health staff, we've tried to encourage the teams to sort of focus on the high-risk patients. So to identify those who are the most vulnerable, perhaps the least well-controlled, so that we can really emphasize, sort of prioritize the follow-up for those patients when we're doing it by phone. And in some settings, we've managed to still have face-to-face consultations, but just very limited, and really focus those on the unstable patients.
One more minute, Philippa, please.
Ooh, okay, so sorry, I'm taking way too much time. So just I think in terms of the key lessons then and the priorities, I think for me, one of the things is that this is COVID situation has really highlighted some of the pre-existing challenges for managing these patients in our settings, and how different they are compared to high resource settings. And this is particularly, for example, the case for diabetes. So where patients don't have access to technology, even to glucose meters, but certainly something like, you know, continuous glucose monitoring, use of pen devices, being able to use insulin out of cold chain. These are sort of things that have made it easier in high resource settings to follow patients at a distance and for them to still get good care. And that's been really challenging in our settings. The patient education issue I also put as a really key thing, and the need to emphasize that, which is something was already challenging in our settings, but Sylvia has already highlighted that. And then I think one kind of final thought is that on the other side, there have been some opportunities that have come out of this. And so I think that the fact that we've really been able to encourage teams to space out visits for patients and to manage them at a distance also represents an opportunity to look at different models of care that could be useful in humanitarian settings, knowing that in these settings, patients often face disruption to access to care for other reasons, for conflict or for patients on the move and that sort of thing. And so that I think one of the important things moving forward will be to try and capitalize on the lessons that we've learned from this and see how it can be applied to humanitarian settings in the future.
Thank you, Philippa. Is that all?
Not really, but I think it's fine for now. We can cover the rest.
Let's give the opportunity to Slim to talk, please. And I'm sure that you'll have the possibility with the questions to expand some of those issues. So now we move to Slim. Over to you, Slim.
Thank you very much, and hello everyone. I've seen that we have more than 110 participants from everywhere, so I hope that you are all well and safe. And thank you again for the organizer for giving us the opportunity to contribute. I will structure perhaps my talk on 3 or 4 points. One is to bring perhaps a regional perspective. I'm working for WHO, but based in Cairo, covering 22 countries of the Eastern Mediterranean region. For those who are unaware, we are a very diverse region, spanning from Morocco, from the western side, to Afghanistan on the east. 22 countries with very diverse health profile, health system story. Half of the region also caught in active, acute or protracted complex emergencies. I mean, you are aware of, Syria in particular, Yemen at the moment. We have a cholera outbreak at the moment in Somalia. And we have, that context, it's probably very relevant to the discussion we are having. On the top of that, and it was something that I think Paul Spiegel was highlighting almost, more than 10 years, I think, ago in one of the Princeps article about the evolving profile of the population of refugees, where chronic disease are also emerging. Clearly in our region with the highest prevalence of NCD and risk factors, we are, having all this is in a melting pot. So this is a bit the complexity of the situation. When it comes to refugee and people on the move, we have, 12 million refugees in the region. Half of them are Palestinian, but we have also refugee population that have been there for years in situation like in Iran, where we have 2.3 people from Afghanistan, so more protracted situation. But on the top of that, and this has been also something that had been highlighted in the past, is that now we are moving also with much more people being forcibly displaced within their countries, with 13 million IDP population. But also, I think I would like to point this because these are vulnerabilities that are not the same between refugee IDPs, but also we have 46 million professional and low-income labor migrants, specifically in the GCC, as you have seen, and you might have seen also recently in Singapore and other countries that were effectively at the beginning of the pandemic were able to control the pandemic, have seen that these vulnerable population where we don't pay enough attention, this is where actually some of the clustering of the cases can appear. I think it's really relevant also to take into consideration the various type of population there. Now, on the discussion about how COVID erupted into that is that we had, that complex environment where the need of refugee population and migrant when it comes to NCD were not already met. And I think one of the importance also of the research is to be much more granular when we analyze these countries about how the country before emergency, any type of emergencies, were prepared to integrate into their benefit package, into their health systems, NCD. And I think without having that lens, sometimes we miss part of the discussion about how mature a system and a country, what has the institutional capacity to deal with that, whether among the official government response, but also through humanitarian partners. And we have done some analysis in the region, and we know that we were already somehow a neglected topic on the global agenda, a neglected topic at the regional level, and in many countries, the response from acute disease models to something more on chronic disease management, on the ability to also integrate population-based preventive intervention with primary health care at the forefront of the response was something that was deficient. So of course, when COVID happened, there had been a lot of disruption, first of all, and I shared in the chat, we have formally, this was something that's so very difficult at the beginning, is to get data of that level of disruption. We have recently completed at the global level across all our member states, and we have a sub-analysis for the EMERA region, a rapid assessment about how much of those countries have been disrupted on specifically on NCD services. And what we have found out is more than 50% of the countries have reported all type of service disruption, including for emergency care services. But in our region, 26% of the country were reporting a disruption even in cardiovascular acute emergency care for stroke, for acute coronary syndromes. Of course, rehabilitation services, screening programs have been much more affected, but even regular outpatient. And I think we need to understand the impact as the evolution of the transmission phases of COVID also have impacted from sporadic to large scale community transmission, like it is the case in many of our countries. And as much as the public health measures were introduced or lifted, the response were different. So that analysis is also important to consider when you look at how services have been disrupted. We try to overcome this by also supporting countries in drafting their COVID response plan. And I put a link to the global platform for the overall response of COVID, where we have supported countries in building their strategic preparedness and response plan. And one of the gap in these global and regional plans were mainly what we call the pillar 9, the aspect about, are you considering in your response not only access in terms of prevention, but access also to treatment for people infected by COVID and the surge capacity that need to be built, but also the ability to look at maintaining essential services, learning from past experiences, including outbreaks like in Ebola, where we have seen that in the ocean of needs, you have pre-existing unmet needs, but you have also that upsurge of needs based on the interruption. And this is exactly what happened again, and we haven't really learned from that, is how you maintain essential services, how you identify what essential services are, but also how you maintain that. I think it's something that we have still to learn from. We have issued a specific guidance on that, and you see it also in the chat. The new version of it was published on the 1st of June, and there is a second part of that document that really tried to highlight from an NCD perspective, what are the essential services, but also in terms of emergency, in terms of outpatient, ambulatory services, but also inpatient specialized services, including from I was yesterday with the African colleagues, International Society of Nephrology for dialysis patients, for instance, how you organize yourself, knowing that COVID can also impact on many organs, have acute consideration, but also in terms of maintaining continuity of services for essential services, not only for emergency, but also for specialized care like cancer or dialysis patients. So this is where we are trying to move forward on that, try to understand first the impact and also how the response can be carved, taking into account also that there is a national response for citizens, but also for that specific subgroup that are even more vulnerable. And here, perhaps what we have learned also is in terms of forward-looking and bridging perhaps the gap between the humanitarian and development nexus is how we can build better. I think one of the pillars of the overall COVID response, the pillar one, is around coordination. How we make our case to further maybe include NCD as part of the response, and also include that vulnerable population, the refugee. There are two specific guidance on this. We have one from the region also about, because for us, it's critical to have the discussion around inclusion of that vulnerable group within the response plan and how you operationalize this, but also building on how can we build a better response in humanitarian settings on NCD, cutting across some of the elements that the colleagues have mentioned. One aspect is the overall inclusion and coordination among actors. We have, in the current response, we have seen that multiple implementing partners working with UNHCR or other colleagues that have their own NGOs have developed models, including alternative service delivery model. I think one lesson learned also from this crisis is that the digital health technology have really emerged as something that we were not prepared. We were not prepared in terms of infrastructure. We were not prepared in terms of legislative and regulatory framework to be able, I was with colleague in Tunisia, they were mentioning, the public sector, we're not able to implement it because even the decree, there was no law allowing us to do telemedicine. So it was in the public sector. So how can we overcome this? But also understanding what kind of typology of health technology are there that have been tested that can be used and shared among countries. Because I've seen a lot of redundancies and different organizations testing their own system without really taking a lesson out of this, sharing those expertise and experiences. So I think the health cluster coordination in countries where we are discussing the response plan for COVID, but also like in some countries in the region that are already involved in like the Syrian response plan, how actually this communicate, and implementing partners that are really like NGOs, having hands-on, maybe how they can better share.
One more minute, Slim, please.
And bring their experience. So I think what we learned from this is, one is that a better bridge between humanitarian and development nexus, building better, looking also from a research perspective, or for more what I was mentioning, just before the call, a social network analysis, understanding that health system institutions are social institutions, having the history and understanding why the NCD wasn't really taken into consideration until now. What can we learn from that is moving away from a kind of very linear or a snapshot view on just some aspect about access to medicine or delivery. I think understanding more the determinants and the social determinants that are behind our inability at the moment to really respond fully for that vulnerable population from an NCD perspective, and addressing progressively the health systems hurdles that we are facing. And there are many, self-care, you mentioned, is only one aspect, I think, but self-care for me is not just about self-management, it's about empowering communities and providers all together. And I think this only happened within specific health systems. I think having a more granular lens on how health system has been built and have taken up, I think that NCD and refugee agenda, I think would be really useful for informing policy. And I think this coordination among academic institutions and this example as a webinar, I think is a very interesting, step taking forward this agenda. Thank you for, and I'm happy to take any question.
Thank you, Slim. I will invite the other panelists to now, if you want to unmute yourself and also put the camera. So Sylvia as well, Philippe, excellent. So thank you for the three presentations. And as you can see, you have a lot of things to say. I have to chase you with the time. I'm sure you can, each of you can speak for 1 hour on this. I'm looking at my phone, not because I'm rude, I'm looking at the questions that you sent. I cannot manage multiple windows in my computer. So Brian is sending me some of your questions, and I will start. So yeah, some of the questions might have been answered, but I will anyway read them. One was in particular about what's your thoughts in terms of the sustainability of home-based care for COVID patients with NCDs in refugee settings. And I think, Philippa, you referred a little bit to that, but maybe you want to, I'll read a couple of questions and then we do a turn. So that's one question. The other one that they're asking about specific initiatives to highlight, I think Slim already shares some of the documents from WHO, but I will give you the opportunity to highlight any other initiative that it wasn't mentioned in terms of NCDs and in the COVID-19 context for humanitarian settings. There is a question about what are the thoughts on strategic SOP management, so for NCDs in lower and humanitarian settings. So I'll stop there and then I'll continue with other questions. So the questions are sustainability of home-based care in the context of refugee settings, and also any other initiative that you know or you would like to share with the audience in terms of NCD in the context of COVID-19. So who would like to start? I don't know, Sylvia, maybe?
Sure. I can start off on the bit of the refugees and home-based care, and I think just giving a bit of reflections from part of what is going on in the 2 refugee camps that we are dealing with in the Kenyan context, and also the other ones that we are working with in Sudan and in other parts of Africa. I think one of the things that can be looked at is working with the existing primary healthcare structures and the community healthcare structures would be able to support the home care aspects of this service provision. So amongst the refugee populations, we normally have the services provided by what we call the health promoters, who would then go up to the, the household level where the refugees are staying and provide them with these services. So leveraging on these kinds of structures would be able to support that process. The sustainability, of course, is a question of neither here. It's a question that would depend on a number of things, because the refugee, most of them are either not staying there for long, others are on transit. There are those ones who are planning to be repatriated, others are planning to be reintegrated. So as the process goes on, I think it's important for a dialogue to happen between the persons providing services in the refugee context and the host government to see how the service continuity can continue. But I think building on the existing primary healthcare structures amongst the refugee operations would be a key supportive structure for the home care services for refugees.
Okay, thank you, Sylvia. And if you don't have any other initiative to mention, I will move to other questions. I think Slim provided the links to different resources, and I'm sure we can talk with Ryan, but I'm sure this could be available for the audience. We'll find a way of getting those links. There were some questions about that. I think there are a couple of questions about technology, about basically, I think there was one question, what's the evidence about its effectiveness, but also other questions that are regarding what are the challenges, legal frameworks, program design, confidentiality, etc. And then if you're aware of any effort of providing digital mental health and psychosocial support service for persons with NCDs. So if, who wants to have a go, maybe, I don't know, Philippa, in terms of these questions?
Yeah, so I mean, in terms of the technology, I think that's something that we're just starting to look at, and definitely there are challenges in terms of, data privacy issues, and that's something that we take very seriously in MSF. So it means that we take some time to work out what are the best platforms to use in terms of technology for reaching patients. So in this COVID setup, I think it's really been teams adapting on according to their context to what they're able to use, and it's generally been just very basic use of phone calls for patients. Our mental health teams have actually been very quick to work out a framework, and they worked with our legal department to see how they can adapt the mental health care to be able to provide telephone consultations. But I think there are, I mean, Slim might be able to contribute, because I think WHO has done some work, as far as I'm aware, on mental health and digital initiatives as well.
So I mean, I think I was going to ask to Slim, I know WHO has different initiatives in terms of digital health, like Be Healthy, Be Mobile, or now you have even a digital department, I think, only a few years ago. So is any concrete initiative that you're aware in terms of digital health and NCDs that you would like to share with the audience?
Yeah, perhaps a couple of remarks. One, I didn't mention in my remarks that we have also set up across all HQ and all the region, the 6 regions of WHO, a working group on NCD and COVID, and there are different, streams of work. Some aspects are really try to understand more the linkages between COVID and NCD, like for instance, gathering the data about comorbidities, as some of the colleagues have mentioned. The poorer outcomes in this specific community, their vulnerability, and how actually can we do it. Some aspect about lifestyle and health promotion messaging, how to maintain the general population, but also people with NCD healthy at home during those lockdown and public health, and physical distancing. But also some of the questions are touching specific alternative model of service delivery, and we have a subgroup working on digital health technology, building on what, there has been quite a long work. If you even Google, on WHO, on digital health technology, typology, classification, what type of services can we provide? You mentioned only one, initiative was the mHealth, Be Healthy, Be Mobile, that have been also implemented in a couple of countries, like Senegal, in Egypt, on using, health technology for messaging, whether on a one mode or bilateral mode. But I think this is only one aspect now. What we wanted to look at is really to understand first, what kind of typology across, the continuum of care, from prevention to management, digital technology can happen, and maybe test. Of course, we cannot recommend one specific app. I think it's beyond that. No, the normative work of WHO is to look at those elements and see, perhaps suggest. We have a compendium of innovative medical devices in the past that have been issued also from WHO. We are trying to have a similar approach now and learn from the current experiences, because countries are not waiting. And you fund platform, and as I mentioned, through NGOs, but also through government, have themselves invested quite a lot during the crisis now in telemedicine across the range of services, mental health, NCD, so you will find a range of activities, but we haven't really capitalized yet on this, and I think this is something that we are working on, is to understand that aspect. And we have other groups that, and as I mentioned earlier, for us, it's really important that we don't stop here for the COVID response. We don't know how long there's a lot of uncertainty about how actually we will be dragged until, we found a vaccine. But I think what we would like to do is to also link this with the current work. Example, access to medicine is a big issue at the moment with the disruption that cut across, importation of active ingredient to the dispatch of medicine for people within countries, to other aspects about, fears of interaction and drugs. So we are trying to work on categorizing what are the access issue for medicine, for instance, at the moment, and addressing some of the point that Philippa was alluded to. We are going now to reopen the discussion about pre-qualification of insulin. Affordability and availability of NCD medicine is very high still on our agenda. So how can we use also the opportunity of the crisis to, as I mentioned, build better, try to reopen some of the discussion we were having. We have, for instance, in the executive board, very high on the agenda recently, the price of cancer medicine was on the global discussion, transparency of the price, pool procurement, better procurement, channels, better forecasting of the requests from countries. These are the kind of building blocks that we would like to reopen, and bridging progressively from the acute response to the more, mid or long-term strategy, because it's not something that we will fix in a very short-term period.
Thank you, Sliman. I'll read another few questions we're having from the audience. Is it advisable to issue masks to NCD patients in the home to reduce the risk of COVID infection? Then there's another question about what are the key research priorities for NCDs, especially for home-based care. Then I think I'll read one more.
Pablo, for clarification, when people say home-based care, are we talking about management of COVID-infected patient at home, or just, the usual patient for NCD management?
I think we'll have to assume, I don't know, that's information that I've been given. But and then the final one I'll say is any, and in a way linked to models of care, is any initiative to leverage informal healthcare providers such as pharmacies, vendors for NCDs management in low-income settings. So they're asking about aware of any initiatives, and this probably is related with research. I don't know, Sylvia, if you want to expand on that or
Sure.
answer, have a first go.
Sure. Yeah, I can have the first go. I think, is it advisable to give masks? I saw on the chat there was a specific question asking if that can be done. I think currently what we are doing in some of these places where the countries have said masks should be availed. Of course, it's looking at the most vulnerable groups to then avail them with the correct masks so that, again, you're not just having them having any kind of something put on the mouth and the nose and calling it a mask. So the challenge has really been availing these populations with the correct type of mask that they need to have. But yes, I think it is advisable because then they are still interacting with populations. We know the challenges we have in most of these settings is doing physical distancing is a challenge. Family members are staying, a lot of them in one room, for example, and they have a diabetes patient there, they have a hypertensive patient. It is very difficult to tell them leave that room and go and stay elsewhere when that is the only place they have to call home. So availing masks is one of the strategies to use. And of course, then looking at other hygiene promotion measures like hand washing and cough etiquette, part of having a more integrated approach to it, not just use of masks alone as one of the approaches. I think that's what I would say. For research agenda, I think I would say there are a lot of things to be looked at in this context of NCD in emergencies and how it should be approached, what kind of models of care and service delivery should be utilized, you know, even just the basic things around access to services for some of these populations. How do we sustain you know, service provision to these populations? So I think there are a lot of items that can be researched on. It's an area that is, I would say, still quite unresearched on, and a lot of topics can pop up. Currently, I know in Kenya, we've worked with the Dadaab and the Kakuma refugees to just tease out what are the needs of refugees in terms of NCD service provision. We did a very quick situational analysis, and out of it, you find a lot of research questions that need to be looked at. And then also we are looking at then progressing on to look at policy influencing and policy environment around NCDs in humanitarian setting. And also that whole bit of it brings in the advocacy agenda, what exactly needs to be looked at. So there are quite a bit of research areas that can be looked at, and it's an area that is quite ripe with a lot of questions that can be answered.
Thank you, Sylvia. Anyone want to add anything, Philippa, Slim, to those answers?
Perhaps one point on the home-based, I think one of the colleague, Lena, was sharing in the chat, precision. I mean, she was mentioning more about how to maintain patient self-care management at home for a longer period of lockdown. And this is something that we have been facing across our countries, reporting some of the issues related mainly, and it will really depend, as I said, of the phases of transmission. Now that many countries in the region are still in the community transmission phases, there has been restriction of mobility. So that restriction of mobility really affected the ability for people with NCDs to reach out to the centers, to the providers, to get access to medication, to be able also somehow to maintain a social life with their own families, sometimes from the fear of being also infected. So some of the recommendation was really one to understand what is the risk and the high risk population. Of course, if you have, someone on a cancer treatment that have had, a chemotherapy or have immunosuppressed is a bit different from someone that might have a hypertension or diabetes. Of course, most of the recommendation were as much as possible to stay at home, be able to continue the medication. And this is where actually those alternative service delivery model have been tested in countries. Some in very stable patients, it's just about provision of drugs and continuous access to drug medication, with people having some instruction over the phone, through hotlines, or through specific telemedicine. And for more complex situation, it was really a triage. A triage for two aspects. One, for so that people do not have the COVID when reaching out the healthcare center, and the triage about understanding whether there is really a need for people to go to the center or getting access to any type of telemedicine consultation if there is a need actually to discuss further. So I think the home-based has become the norm during specifically the lockdown, but the ability for countries to deploy those services has been something that we are learning by doing, basically.
Thank you very much, Philippa. I think I will now give you, each of you, if you want, one final minute to say maybe what are the kind of key messages you like to share with the audience. So maybe we can start with you, Philippa.
Sorry, clearly I have technological issues as well. So key messages. Yeah, I think there are many things. I think just coming back to the point of the sort of the research imperatives and what's important here, I think that there are, I mean, I've already mentioned the opportunities from this, and there are a lot of lessons that are being learned from this. And I think that it's really important that we try to document what we're seeing in terms of challenges to access, whether they're new ones or whether they actually highlight some of the pre-existing issues of access to care that people in suffering NCDs were suffering in humanitarian settings, and the kind of deficiencies in management of NCDs in humanitarian settings that make this adaptation to COVID context changes in management more challenging compared to other settings. But really monitoring these innovations in terms of the models of care and trying to get some evidence out of those to see how they can be really useful in the future in terms of management of patients. You know, I think there's a need for some guidance on how do we task shift and how do we task share and use different members of the healthcare system and members of the community to have more community models of care that are useful in disruption of any kind of access to care, whether it's from a pandemic such as this or whether it's from other outbreaks or from conflict or for people on the move and so on, and guidance on the use of technology to support in these situations. I think there's also a need to make sure we maintain a focus on other key issues of advocacy relating to NCDs in humanitarian settings, and realizing that global attention perhaps is shifting and funding is going to shift so that we make sure that these patients do not get lost amongst the redistribution of funding and attention. And that there's really a need for an ongoing focus on patient empowerment to help patients to better survive these kind of disruptions to their care. So in the end, I guess a need to continue to innovate, educate and collaborate, as was mentioned, to make sure that this particularly vulnerable population are really better prepared for these kind of disruptions.
Thank you, Philip, very much. So I think, I mean, Sylvia, you want to say your few final key messages?
Yeah, I think for me, the key messages would be predominantly to one is looking at how we can, as policymakers, people who provide technical assistance, people around research, look at how we can prioritize the whole agenda of NCDs in emergencies, not just during COVID, but any other emergency. We're looking at floods, drought, we have the migration issues. So we need to really look at how we can push for the prioritization of this. And maybe from the research side is providing, solid evidence that can be able to inform the policymakers and decision makers on what direction to take and how to manage NCDs in emergencies, because it's still an area that we are struggling with as a humanitarian, sector. And then also looking at the whole aspect of really patient empowerment. I know Dr. Slim mentioned around having it from a more holistic perspective, but I think looking at patient empowerment, looking at self-management, self-care as one of the key strategies to ensure that patients who find themselves in any humanitarian crisis are able to take care of themselves, to a large extent for a reasonable time, so that then they are not relying on other systems or other people to give them care. So if we can be able to really focus on self-management and self-care and really empower the patients to really take care of themselves. My usual small slogan that I say we need to demystify, to demedicalize, and look at a way of making NCD management very simplified to the patients and not very complicated for them. I think for me, those would be the key parting shots.
Thank you, Sylvia. And
thank you.
Slim, any final thoughts to share with the audience?
Very much along the line of what Sylvia and Philippa has mentioned. Perhaps I would just structure it around one is advocacy and the policy dialogue on one, the NCD inclusion in both humanitarian settings, but also in the overall development work. The SDG agenda, the discussion about universal health coverage, the global compact, I think that NCD is still very much neglected, despite being the most common burden now, I mean, as the country are evolved, even in low-income settings more and more, is something that haven't been really formulated well from our perspective. Also, perhaps the way we have been advocating for it is not sufficient, because we don't see things moving, and the premature mortality related to NCD is diminishing, but the risk a bit, but not much. And in some area like diabetes, related death is increasing, even, and obesity related rates. So there are things that there is a problem there that is more than just a health issue, that is a development issue. I think we haven't put it yet on that agenda, on both humanitarian and the development agenda, which also leads about that issue of coordination among humanitarian actors, I think. And what is important for me is building a national ownership. We know that sometimes with some certain government in situation of conflict in particular, is difficult to government, but at the end of the day, we need also to create that national ownership, whether on the research part, but also on the collaboration, which means also mainstreaming and strengthening the system at a national level. I think should be something that we focus more. Many of the operating models of humanitarian agencies also are a kind of teams from outside. It's good, but the handing over to the countries, creating that ownership, I think, and it relates to the self-care aspect that Sylvia was mentioning, I think, is also building empowerment of communities. I think more than just the technicalities about service delivery model, I think is how we create progressive ownership. And the last point, perhaps on the research agenda, is really also to document and share those experiences further on specific themes that we have highlighted. Some aspects are around the overall governance, but some aspect might be also more on the service delivery model, as we have alluded to. Thank you.
Thank you, Srima. I will pass over now to Paul. Before that, I just want to thank you all, and thank the audience. I think, as you can see, there are a lot of, I think, agreement on many of the problems and a lot of activity already ongoing, but it's clear that the message of better coordination is needed. And I think keep looking at this space, the website of COVID-19 Humanitarian, a group at the London School and other colleagues who are working, trying to collect some of the resources and working on some guidelines on NCDs. So we will try as a research group, and we'll be talking with Slim before the webinar, that this is something concrete that will hopefully come from this webinar. So now I will hand over to Paul, who I think is going to talk about next webinar. Thank you.
Hi, everyone. Thank you, and thank you all for participating. Really appreciate it, and a very, very important webinar. Next week, we're going to have a change, and we're going to move towards attacks on healthcare workers in COVID-19 situations. Thank you again, and this will all be recorded and shared with you shortly. Thank you.
Thank you, everyone, again.